Thank you for joining Cancer Support Community Atlanta for this 4-part physician-led education series, a focus on cancer in the African American community. This program focuses on colorectal cancer and is facilitated by Dr. Erin King Mullins with Georgia Colon and Rectal Surgical Associates. If this is your first time participating in a Cancer Support Community Atlanta program, we invite you to visit our website and complete a new attendee form to stay connected to all future programs. Welcome everyone to the second installment of the 4-part series of Focus on Cancer in the African American Community, with today's program focusing on colorectal cancer. I'm Katie Armsby, the Program Outreach Director with Cancer Support Community Atlanta. Cancer Support Community Atlanta continues to offer free support programs virtually to those affected by cancer, which includes a colorectal support group. This group meets monthly virtually and is facilitated by a licensed mental health professional. We invite you to visit Cancer Support Community Atlanta's website, cscatlanta.org, where you can find a complete schedule of the virtual events available. You can also register for the remaining 2 physician-led programs in this series at our website. As a reminder, everyone will remain muted for the duration of the program. We invite you to enter questions into the program chat box, which will be addressed during the Q&A at the end of the program, time permitting. I want to welcome our series moderator, Dr. Rylan Gore with North Atlanta Breast Care. Dr. Gore will be moderating this series and will be facilitating the October 9th presentation of Focus on Breast Cancer in the African American Community. Dr. Rylan Gore is a board-certified, fellowship-trained surgeon in breast surgical oncology and specializes in the diagnosis and surgical treatment of benign and cancerous breast cancers, as well as all breast-related disorders. Dr. Gore is a highly trained physician skilled in advanced breast surgery procedures and minimally invasive techniques. She practices with North Atlanta Breast Care and has served in community outreach programs as an advocate to help spread breast cancer awareness. So with that, welcome back, Dr. Gore, and I'll go ahead and pass it off to you to introduce today's presenter.
Hi, everybody. Thank you for joining us again this week. I'm so excited to have you back. I hope you guys enjoy what we have planned for you today, and I'm very excited and honored to introduce Dr. Erin King Mullins. She is board certified by the American Board of Surgery and the American Board of Colon and Rectal Surgery. She is a fellow of the American College of Surgeons and the American Society of Colon and Rectal Surgeons, where she serves as the co-chair of the Diversity and Inclusion Task Force, which is very important right now in 2020. We need all of that right now. Dr. King Mullins currently practices at Georgia Colon and Rectal Surgery Associates. She treats all colorectal conditions and also has a special interest in minimally invasive and robotic surgery. Without further ado, I'm going to turn this over to Dr. King Mullins, where she's going to speak to us today about colorectal cancer in the African American community.
Good afternoon, everyone. Thank you so much for joining us this afternoon for a very, very important topic today. So I'm really getting used to these Zoom talks, and so you may see me moving around and waving my hands because I'm so used to speaking in front of a group of people. And so I want to treat you all like you're just right in front of me and be as interactive as I can with you all as possible, even though I can't necessarily see you. So today, we really want this to be a great conversation, and I want you all to be comfortable. Today I don't plan on giving you a lecture on the biology and basics of colon cancer. What we really want to do is understand what colorectal cancer is and how it affects the African American community. And I want this talk today to really be able to lay the foundation for you all, the listeners, to be able to start those conversations with your friends and your family and your physicians. So we'll talk a little bit about the statistics about colorectal cancer in the Black community, and then we'll kind of move on to some of the more basic information surrounding colorectal cancer itself, its diagnosis, its treatment, some of the symptoms, and the like. And so please don't be afraid to ask any questions. Unfortunately, we won't be able to do the live questions, but the chat box is there, and I want you all to feel comfortable to ask any type of question, okay? Okay. So in speaking about colorectal cancer specifically in the Black community, So this is a statement that I actually came across in planning my presentation on the American Cancer Society, and I think it's a very important topic right now. And so this was a statement: colorectal cancer is the second deadliest cancer in the country. And this is from Dorado Brooks, MD, the Vice President of the Prevention and Early Detection at the American Cancer Society. This disease is ravaging the Black community, and it is important as ever that everyone accept and is receiving the recommended screenings, access and receiving the recommended screenings. Even during the coronavirus pandemic, necessary screening tests remain available to prevent the disease or find it at an early, more treatable stage. And so I'm very enthusiastic that we are having this conversation during the coronavirus pandemic, because I know a lot of people have fears and concerns about maintaining their regular health visits during this time frame, which will be, very important. So colorectal cancer is the third most common cancer diagnosed in the United States. It is estimated that just under 150,000 cases of colorectal cancer will be diagnosed in 2020. In particular to the African American community, the rates of colorectal cancer are higher than any other racial or ethnic group in the United States. African Americans are 20% more likely to get colorectal cancer, and they're 40% more likely to die from colorectal cancer. Now, before 1989, colorectal cancer was more common in the white community, and since this time, there has been an increased incidence in the African American community, and we'll start to talk a little bit about why those reasons are through the course of our conversation today. So why? So there are two broad categories when we talk about the risk of the African Americans having more likely to develop colorectal cancer: risk factors and access to care. African Americans are more likely to have lower paying jobs. 21% of Black Americans live below the poverty line in comparison to 9% of whites. More African Americans are more likely to be uninsured or underinsured. So when just looking at even private insurance, 57% of Blacks have private insurance versus 73% of white patients. African Americans are more likely to live in food deserts and have less access to healthy, fresh food options. This forces them to rely upon processed foods that have higher levels of salt, saturated fat, and limited nutritional value, which contribute to some of the other medical problems that we see that increase the patient's risk for cancer. And African Americans are more likely to have a lower quality education and housing. For example, 22% of Blacks versus 36% of whites will have a 4-year college degree. So we talked about colorectal cancer here on this slide being the third most common cancer diagnosed in the United States. It is the third leading cause of cancer death in Black men and women. So this is very important. So it's not about just them being more likely to develop the colon cancer. For some reason, they're more likely to die from the colorectal cancer once it's been diagnosed. And colon cancer is a very treatable disease. So we're going to talk about why that is. African Americans are more likely to be diagnosed with a later stage, a more advanced cancer. And this is what's going to contribute to their decreased survival. So 5-year survival rates, which means 5 years out from someone's diagnosis, what percent of people are still alive after obtaining that diagnosis? The survival is less in Blacks than it is for whites. So at 5 years from diagnosis, only 58% of African American patients will still be alive from their diagnosis as compared to 67% of whites. So we're seeing a 10% difference there. And research has found that 19% of cancer deaths can be directly related to lower screening rates, meaning not detecting cancers early or not detecting polyps early and removing them and preventing them from turning into cancer. So there are other factors that cause decreased survival. So some of the comorbidities, so the diabetes, the hypertension, high blood pressure, high cholesterol, Some of it's also related to characteristics in the tumor. We'll talk a little bit more specific in specific details about cancer later on in the talk, but here on this screen, what we're really seeing, on the diagram, there's a line that's going down the center of the colon, which divides the colon in the right and left. And then the picture you're seeing here is a little bit of a mirror image. So the right side of the colon is actually on the left side of your screen, because if you could imagine you looking at someone, when you look at someone, their right hand is actually going to be on your left. And so that's why it looks like that on the screen. But African Americans are actually more likely to develop cancers on the right side of the colon, which actually those cancers can be more aggressive. And we don't really know exactly why that is as of yet. Other factors causing decreased survival are related to treatment. Black patients are less likely to receive the recommended surgery, chemotherapy, and radiation therapy. And what's important to know is that there have been studies that show when Black patients receive the same treatment as their white counterparts, they have similar outcomes. And so we have to figure out why they are not receiving these same treatments. And this highlights that access to care plays a big role in current disparities. Okay, so now we're going to talk a little bit more about colorectal cancer itself. So colon cancer starts as a polyp in the colon or the rectum. And so this is why screening is important. The best way I describe a polyp to my patient is like a small mole that's growing on the inner lining of the colon. And so a colonoscopy can actually detect polyps as small as 1 to 2 millimeters in size. So, I mean, that's like the tip of your finger. And so obviously that's not going to cause any symptoms. You're not going to know it's there, but that's what over the course of years can grow and develop into cancer. And that's why it's important for screening, so we can catch those polyps at such an early stage that they can be removed and prevented from turning into cancer. So this is one of the diseases as far as where you can actually, quote unquote, cure colorectal cancer before it even develops. Currently, the American Cancer Society recommends that all patients be screened at the age of 45, and as well as our American Society of Colorectal Surgeons. That is our current recommendation. So what are the signs, what are the symptoms of colon cancer? Many people have no symptoms at all. Sometimes it can just be found on a screening colonoscopy, meaning you don't have symptoms. Your physician is going inside your colon to look for polyps, and they actually find a cancer, so you didn't have any symptoms. Other symptoms, as listed on the screen, include a change in your bowel movements, so newly developing diarrhea or constipation, never feeling relieved when you have a bowel movement, noticing that your stools are more narrow, having blood in the stool, whether it be bright or dark, abdominal discomfort, losing weight and you don't really know why, constant fatigue, vomiting. There are other, very vague symptoms, but these are the most common symptoms that are going to be most directly related to colon cancer. And so if you have any of these changes that persist for 2 weeks or more, that is when you go seek medical attention to get further diagnostic testing, further evaluation to see what is causing this persistent change. So how do you look for colon cancer? How do you look for polyps? And so a colonoscopy utilizes a camera that goes into the rectum and looks all the way around the colon, all the way until it meets the small intestine. And what we like about this test is the fact that it can not only be diagnostic, meaning you can actually find something, it can also be therapeutic, meaning you can treat or remove polyps at that same time. There are other tests that are not invasive. There are stool tests where you leave a stool sample. These will look for blood or cancer DNA in your stool. Certain radiographic, or what we call our imaging tests, they will help identify whether or not there's cancer that exists in other parts of your body. So these imaging tests play a much bigger role once you've actually had the diagnosis of cancer, as opposed to actually diagnosing cancer. But there are what we call virtual colonoscopies that are certain CT scans that can be used in lieu or in place of a colonoscopy, but we like to limit those to certain patient groups that may not be good candidates to undergo the process of a colonoscopy, as a colonoscopy does require a time in the hospital, sedation through the IV, so there may be risks of anesthesia. Also with a colonoscopy, if you have to remove a polyp or do a biopsy, if someone's on blood thinners, that can increase their risk of bleeding. So there are different reasons that a patient may be more of a candidate for a virtual colonoscopy. But again, I always refer back to the concept that the colonoscopy is both diagnostic and therapeutic, so you can treat something at the same time. If something were to be detected, say, on a stool test or on a CT scan, then a follow-up colonoscopy will need to be performed to officially diagnose and see that problem and perform biopsies. Surgery is designed to remove a tumor and its surrounding tissue, and this will be tested to determine the type of cancer it is and the stage of the cancer that's present. So again, surgery is a little bit more relegated to treatment, although sometimes in certain situations if patients are experiencing symptoms or heavy bleeding or a blockage in their colon, the only answer you have is to take them to surgery to alleviate the bleeding or to alleviate the blockage, and then you're subsequently diagnosing cancer if it's present that led them to have that situation. So here's a picture of the staging process when we talk about colon cancer. So on the far left, you see stage 0. That's technically not a cancer. That's technically a polyp. It's just confined to the most inner layer of the colon wall. Stage 1 is a tumor that's starting to grow into the colon wall, and it is 2.5 centimeters or less in size. 2.5 centimeters is roughly an inch. So if you want to, if that helps you better gauge the size. Stage 2 means that the tumor is greater than 2.5 centimeters, but it has not yet gone all the way through the wall where it can reach the lymph nodes. So stage 1 and stage 2 is what we consider local disease. It's just confined to the colon. Stage 3 is what we call regional disease. This means that the tumor, no matter what size it is, has gone far enough into the wall of the colon that it has reached the lymph nodes. So this is where we get stage 3, and this is the precursor to allow this cancer to potentially go to other parts of the body. That's why the lymph node status is important. And then distant disease, or stage 4, means that the cancer cells have spread beyond the lymph nodes and have gone to other places in the body. So what are our risk factors? So we like to divide these into 2 broad categories. At the top, you will see what we call our non-modifiable risk factors. This means there's nothing you can do about having these risk factors. So these are reasons that you have to screen and look and be more aggressive for detecting polyps and cancers. So age. Just like women get mammograms after a certain age, just like men get prostate exams after a certain age, we recommend starting at age 45, colonoscopy or whatever screening matter that, screening method you discuss with your physician. You're more likely to develop polyps after a certain age, and so that's why you have to start then, and you obviously can't go backwards in your age. Having a family history of colon polyps, of colon cancer, and certain other cancers, having an inherited genetic syndrome. Again, this is a factor that you cannot change. And so the importance here is having those discussions with your family and really understanding what medical problems run in the family to understand when you should be screened. Should you start at 45 or even earlier because you're at higher risk? You having a personal history of polyps means that you need to have your colonoscopies and your testing on a more regular basis. Or if a patient has a history of Crohn's disease or ulcerative colitis, which we call inflammatory bowel disease, those patients have an increased risk of colorectal cancer, and so they will begin monitoring for colon cancer earlier than the average person in the population. At the bottom of the screen here, you'll see what we call our modifiable risk factors. So diet. The diet you want to consume should be mostly plant-based, high in fruits, high in vegetables, high in whole grains. Diets that are high in red meats, saturated fats, those are things that can increase your risk of colon cancer. Smoking increases the risk. It's not on the screen, but excessive use of alcohol is actually a risk factor as well. Lack of physical activity and obesity, all of these are risk factors that you can change. Now, is eating a steak, once a week going to guarantee you have colon cancer? By no means is it, but a combination of all of these things can work together to your detriment if you're not, mindful of all of those things and maintaining a healthy diet with also, maintaining your physical activity. Treatment for colon cancer. So at the top here, you'll see we have listed surgery, chemotherapy, and radiation. These are your mainstays of therapy. Other options include immunotherapy, biologic therapy, clinical trials. These are going to be relegated to those with either the rarer cancers, those that don't respond to the mainstays of therapy. And so such research and study has been done on colon cancer for so long. There are standard protocols, standard surgical procedures, standard chemotherapy. Radiation really mostly only applies to rectal cancer, but no matter where you go in the country, if you're in Florida, if you're in Washington State, if you're at MD Anderson, if you're at Northside, there are certain protocols to where patients will receive the same treatment no matter where they are. So surgery, this is going to be your go-to when possible. The goal is to remove as much of the cancer as possible and allow for cure. So these are possible in stage 1, stage 2, and stage 3, meaning either your local disease, stage 1 and 2, when it's just in the wall of the colon, or even stage 3, when it has started to go to the lymph nodes. During surgery, you are removing the colon and the surrounding tissue, which includes the lymph nodes. And so you're removing the lymph nodes and hopefully preventing further spread of the disease. Chemotherapy. Now, there are 2 types of chemotherapy. Adjuvant chemotherapy just means that you're given the chemotherapy after surgery. Now, if someone has a stage 1 cancer or certain types of stage 2, typically surgery is all that's needed. Certain types of stage 2 and all stage 3 and above will require adjuvant therapy, because once those cancer cells have started to migrate out of the wall of the colon, that is when there's the possibility for it to spread elsewhere. And unfortunately, if it's beginning to spread elsewhere, if there's microscopic cells anywhere else in your body, that won't be able to be picked up on a CT scan or an MRI. And so the chemotherapy is a little bit almost like of a mop-up job. It's going to get rid of those cells that you can't see with the naked eye. Neoadjuvant therapy means that you're going to get chemotherapy prior to surgery. And this is relegated to certain instances, most often rectal cancer, when someone also needs radiation so they can start shrinking the tumor in prior to having surgery. And then there's maintenance chemotherapy designed for patients with stage 4 disease, when you're trying to either maintain or prevent further progression or advancement of the disease. Radiation. Again, these are targeted areas, mostly for rectal cancer. You target the tumor or the tumor bed after the cancer has been removed. But it's also targeted for certain areas in patients with stage 4 disease. If they have a site of cancer in their liver or their lung that's isolated to a confined area, the radiation oncologists are great, and they're able to target that radiation beam to burn and kill that tumor. Chemoradiation is the combination of chemotherapy and radiation given during the same time period. And the concept there is the chemotherapy is given to make the tumor more sensitive to radiation so that the tumor can shrink and respond. So what are our take-home points for today? You know, Again, today was just really a baseline for us to be able to start those conversations with your friends, with your family, with your physicians. Everything is going to be individualized. So even though the basic screening age we're recommending is 45, based on your family history, if there's a genetic disease that runs in the family that predisposes you or your family members to cancer, some people may even need to start colonoscopies in their 20s. So our take-home points: African Americans are disproportionately affected by colorectal cancer, but this doesn't have to be. Colorectal cancer is preventable and it is treatable. So what can you do? Know your family history, live a healthy lifestyle, and get screened. Thank you so much for joining us today. I'm going to turn it back over to our moderator, Dr. Gore.
All right, there we go. I'm back in business. Thank you so much, Dr. King. We really appreciate that info. Before we get to the question and answer session, I do want to reiterate that Northside has a plethora of resources for patients as it relates to screenings. Number one, we do offer most cancer screenings, including free skin and free prostate cancer screenings. And there's a list, a full list of complete times, dates that you can access on our website. That's listed right there, northside.com/health screenings. Of note, we also do have resources for patients that need screening mammograms. Some of these are free. It's dependent on certain financial eligibility. So just plug into that to get more information and to see where you stand for your free mammogram potentially. We do have information on clinical trials as well. The website is listed there, so please access that if you or somebody you know needs help and needs treatment. We may have something for them that can help them along their journey. And also, we do have a robust genetic counseling group. They're fantastic and do a great job with my patients, and I'm pretty sure Dr. King Mullins could attest to the same. And so please look into that. That's something we need to do more of as we talk about, our family history, but also how our genetics may influence our cancer risk. And so that's something else for you guys to be mindful of. And then my friends, my boos, the cancer support community at Atlanta has a plethora of resources also, everything from yoga, chair yoga, Tai Chi, nutrition classes. There are monthly oncology nutrition seminars led by an oncology dietitian with Northside Hospital Cancer Institute. And so there are so many great resources through Cancer Support Community that's available to everyone. And there are oncology support programs available virtually as well. And so please visit cscatlanta.org for more information on the additional resources we have for you. And also, these recordings will be available on the website. Last week's fantastic presentation by Dr. Glasgow on gynecological cancers in the African American community is up on the CSC website. So if you missed that presentation, please plug into that and take a look on the CSC website. And I think we're going to dive right into questions now for Dr. King. So one question that came up: is a polyp similar to a tumor or a cyst? You kind of touched on this at the beginning of the presentation, but I'm sure if somebody asked it, there are other people thinking it.
Sure, definitely. So a cyst is going to be something that's fluid filled, and that's typically found in what we call our solid organs, like the kidney or the liver or something like that, whereas our colon is a tube and it's hollow. And so, a polyp is going to be basically a very small tumor, the beginnings of a tumor, something solid that's growing on the inner lining of the colon.
Next question that I thought was a really good question for some people who are afraid of getting their colonoscopy. Can you discuss the discomfort, if any, that exists after a colonoscopy, and for how long?
Sure. So much has changed with the technique and how we perform colonoscopies over the past several years. Number one, the medication that you're given during the procedure has changed. It's not general anesthesia. We call it twilight or monitored anesthesia care. And so an IV is placed. The anesthesia team is there. You just have a little oxygen in your nose, so you're breathing on your own. You're in deep dream, kind of la land. And then during the course of the procedure, what we do is we inject air into the colon just so it can kind of blow up almost like a tent, so you can expand the wall and see it really well. And so we try to suck out as much of that air as possible at the conclusion. So afterwards, people can experience some cramping associated with that. They can pass a lot of gas, which can sometimes be a little embarrassing, but typically it should not be painful. Some patients may experience some discomfort if they've had, multiple previous surgeries on their abdomen that relates to scar tissue, and so their colon may not be as straight as we would call it, but by and large, it is considered a relatively painless procedure.
Perfect. Thank you so much. Another good question that we just received, is there good data on the disparities of screening rates of African Americans versus other ethnic mixes?
There are, the American Cancer Society, cancer.org, actually does a great job. They have a pretty extensive document that highlights some of the rates of cancers in various minority and ethnic groups in the United States. And so the focus on, the reason for African Americans today is because the African American community is the most affected, but definitely a lot more information can be found there if you're interested in a particular minority or ethnic group.
And speaking of the focus on African Americans, this question came in, which I think is very important to discuss considering everything going on. Can you discuss why the recommended age for colonoscopies changed from the age of 50 to the age of 45?
Yes, definitely.
Briefly.
Yeah. Over the past 20 years, for some reason, we have been finding increasing rates of colorectal cancer in patients under the age of 50. And so even finding polyps in those patients. And so we don't know scientifically exactly why that is the case. And so the concept is once we lower the screening age, we can then detect polyps sooner, detect any cancers earlier, to decrease the rates of death and to increase the overall survival from the disease.
It seems to me, though, that specifically in the African American community, I think that this was a very bold move to drop it from 50 to 45, because I think, as both of us know, in our training, we've seen all kind of crazy things, and you're like, hold up, this person is very young. And so I think it's absolutely necessary. But my issue is that I find that even with the drop to screening to the age of 45, African Americans are still affected a lot in late 30s, early 40s. Chadwick Boseman, my Black Panther, he died at 43, and he's been dealing with this for at least 5 years. So that means he was diagnosed in his late 30s. And so do you think that there should be some kind of consensus statement in that if people want to get screened earlier than 45, that they have the option to do that, and should it be covered by insurance?
Sure, and that's a very loaded question in many ways, and I'll kind of go through it as best I can to give the answer. And one of the, when I've had, many conversations with people about the Chadwick Boseman situation, we obviously don't, he was a very private first person. We don't know all the ins and outs of his diagnosis. And so one of the things we don't know is, did he have a family history? And so I think one of the biggest things, like I said, starts with having those conversations. Sometimes we get embarrassed. People don't like to talk about their medical problems, but you truly have the opportunity to save someone's life if you have been diagnosed with a polyp, if you have been diagnosed with cancer, to share that with your family. Because, for example, you get your screening colonoscopy at 45. If you are diagnosed with a polyp at the age of 45, that then means that your children, your first degree relatives, need to start their colonoscopies at the age of 35 or 10 years prior to diagnosis. And then if you're diagnosed at 45 and you have any siblings, if they have not yet had a colonoscopy, they are now immediately due, for a colonoscopy. So much really does hinge upon those conversations in families, because that also changes the screening age. Also symptomatology. We talked about, a lot of times patients, are afraid to bring up to their physician, their friends and their family members if they've seen any rectal bleeding. And so, yes, sometimes it might just be a hemorrhoid, but if it's something that persists, that's when you should seek further treatment and evaluation. And so those are the two kind of biggest things that will help us as we move forward in the future, once people are truly getting screened at the appropriate age, and then their family members truly being then screened at their appropriate age based upon their family history. That will help us over time determine whether or not the screening age should be lowered. And there are some organizations who at this point do believe that African Americans should actually be screened lower at the age of 40. So more research is going on about that, but I think the target is 45 right now. And to some degree, the target has been lowered to 45 in hopes that they will get the colonoscopy by 50, because I think somewhere only about, 65% of those who are eligible to get screened do get screened. They may delay it. So a lot of times I'll see patients who are, my doctor's been telling me for the past 2 years. So if you lower the age, maybe they will go ahead and come a little bit sooner so we can catch it.
Awesome. Thank you so much for that. I know that question was very, very loaded. Another really good question. Are rates of appendiceal cancer higher also among Black men and women?
That has not been borne out, but appendiceal cancer is such a rare cancer.
Right.
It is hard to get the adequate numbers of patients to get some of that other stratification and looking at the age, the race, and the other risk factors of diagnosis.
Thank you. There's so many good questions coming in. Can you discuss a link between diet and processed food and cancer risk? If you live a healthy lifestyle, this is a two-part question that was submitted.
Sure.
If you live a healthy lifestyle and have no family history, can you delay screenings? This isn't even my presentation, but I'm saying no. No, you cannot delay the screening.
No. And again, because, one of those first non-modifiable risk factors in general is just age. After a certain age, you're at more risk of developing polyps. And so the answer to the second part will be no, you would still at least you still need the screening. But, one thing, and I failed to mention during the presentation, an average risk individual without any family history, without any symptoms, that is purely just getting a colonoscopy for screening. If they do not have a polyp or anything abnormal on their colonoscopy, they don't need their next colonoscopy for 10 years. And so other reason, if you find polyps, if you have a family history, you have to be screened on a shorter interval. So you still need the colonoscopy, but you won't need it as frequently if everything's fine. As it relates to diet, I'm going to kind of break it down a little bit to a science to kind of, as they say, put it where the goats can get it, so you can really understand the importance of a healthy diet, especially high in fiber. So fiber is not something that your body can actually physically break down. There is good bacteria that live in the colon that actually break down that fiber into this product called butyric acid. This is actually literally the fuel, what feeds the colon cells. And that's why it's important to maintain that healthy diet high in fiber so that that bacteria can break it down. Diets that are higher in saturated fats, red meats, processed foods, the way your body actually breaks that down, especially red meat the byproducts are broken down into these oxygen radicals and various other biochemistry fancy things that are to some degree toxic to the colon. So again, it's not that you can't eat it at all, but on a limited basis. You don't want to keep exposing your colon lining over and over to injury, and it not be able to heal itself, and then you start developing polyps and those problems. So that's why it's important to have the healthy diet.
Perfect. Another good question. So many doctors suggest colonoscopies or just suggest colonoscopy. Do you recommend any other tests, or do you recommend one test more than another as an acceptable test?
So I have two answers to that. My first answer is, any screening test is the best test. So if people are afraid to have a colonoscopy and they want to have something else, I'd rather you get some sort of test and get screened than nothing at all. That being said, the reason why the colonoscopy is advocated so much in those who are, healthy and able to get it if they don't have any other what we call our contraindications, is that fact that it can be diagnostic and therapeutic, meaning you can find something at the same time and go ahead and treat it. Whereas any of the other screening tests, if something comes back normal on those, then you still have to follow up with a colonoscopy for further investigation and treatment. Also, those screening tests have to be, outside of a colonoscopy, have to be performed more frequently. So it may be that those, if you're getting kind of the stool test, depending on which one you get, you may have to get that either annually if it's just looking for blood, or every 2 to 3 years if it's one of the more specialized tests. Whereas again, if you have a colonoscopy and it's negative, even if you have a family history and your colonoscopy is negative, you're good for 5 years. If you're average risk, no other family history, no problems, no biopsies, again, if you get the colonoscopy and it's normal, you're good for 10 years.
And kind of in the same vein, how many of the listed symptoms do you need to have before being concerned about colon cancer?
It's not necessarily the quantity, it's more so the length of time and, any other situations surrounding it. Something that persists, meaning, if you had a cold or a flu or some sort of respiratory infection and you got placed on antibiotics for a couple of weeks and you had diarrhea, then, we can attribute it to that. Now, if you out of the blue developed diarrhea and it persisted for an extended period of time and you can't really attribute it to anything else, then those are the reasons that you need to seek treatment. But it's not necessarily having multiple. It can only be one.
Here's another participant question. I'm 50 and my doctor hasn't recommended a colonoscopy. Could this be because I don't have a family history? Should I inquire about this? I'm going to go out on a limb and say
yes.
Absolutely. Please inquire.
Yes, please inquire. You are definitely of screening age, family history or not. It's time.
Here's a more technical question. Would you please explain the measurements when getting a colonoscopy? For example, someone suggested people need to get between 140 and 150 centimeters for a colonoscopy. Is this how far the scope goes into the colon?
So the average person has anywhere from 4 to 6 feet of colon, and so the way you determine if you've gone far enough is where you meet basically where the colon meets the small intestine. So that is documentation of having a full colonoscopy. There's this little, what we call, for technical sake, the ileocecal valve. That is the valve that checks from the end of the small intestine into the colon. So you have to reach that to make sure you've done a full colonoscopy and seen the entire colon.
Yep. Let's talk about the HPV vaccine. Does this help prevent colorectal cancer?
No. The HPV vaccine is related to the HPV virus and anal cancer. And so actually at some point in the future, I am going to give another lecture and talk on that. So stay plugged into CSC Atlanta so you can see that when I do it.
We cannot wait for that. Another good question. can you share your perspective? This is kind of having to do with screening in the time of COVID. Can you share your perspective on at-home colorectal exams? You kind of touched on this already. Are they a safer option during COVID-19? And are they as precise as an in-person screening? We've kind of answered some of this already, but.
Sure. You know, a lot of the answer to this really just depends on, number one, you know, have you delayed screening? Like, are you behind? You know, I would say, you know, if you're 55 and you haven't gotten any screening test at all, like, I would definitely advocate, you know, for a colonoscopy. But you have to do what you're comfortable with. You know, these days I can only speak for, you know, my experience in my institution. We are testing everyone who comes in for an outpatient procedure, whether they stay in the hospital or they're just having like a colonoscopy coming in, coming out same day. We are having everyone get COVID tested prior to that procedure. We are having everyone wear a mask. Everyone is wearing appropriate PPE. So the rates of, you know, contracting COVID for your screening test when you're going to be in and out and not really in close proximity with some one person for an extended period of time is pretty rare. And so you really have to, you know, speak with your healthcare professional, even if you want to just book a telehealth visit with your primary care physician to really understand what your risk is and, you know, what your risk of COVID is, obviously, if you have other, you know, medical problems versus your risk of having a polyp or having colon cancer. But, you know, in general, we don't know really how long this pandemic is going to last. And so you really don't want to delay your routine maintenance, you know, evaluations too long.
Perfect. So here's another one. I don't know if Dr. Glasgow is still in the chat or not, still in the room, but she may be able to actually plug in on this as well. During a colonoscopy, my physician found endometriosis on my colon. Can you discuss any association?
Yes, endometriosis, pretty rare that it affects the colon, but it can. And really the decision to do anything about it or not is related to your symptoms. And so if it's just something that was found and it's not causing any problems, then it can just be left alone, especially if you're just undergoing medical treatment for endometriosis, which Dr. Glasgow, I know, can speak a little bit more to that. I know sometimes there's hormonal therapies and things like that. And so if the medical treatment is keeping your endometriosis in control, you don't have to have any surgery or anything for it. If the endometriosis is causing, you know, issues with the colon as far as blockages, bleeding, anything like that, those are reasons to discuss having a procedure or a surgery.
And Dr. Glasgow says that she agrees completely. Another question. What has the response been from your African-American and minority patients as it relates to encouraging them to get genetic testing?
In some instances, it's been a little bit hit or miss, and I think a lot of it really just relates to what their family dynamic is. You know, there are some families that are more close-knit than others. Some are a little bit more tight-lipped and, you know, want to play everything close to the vest than others. But I think in general, whenever I've had that, you know, that heartfelt conversation with them, just to let them know, you know, that we really do have the key, the ability to save each other's life in our hand. And with as far as the genetic testing, a lot of times I refer my patients to genetic counseling, and I tell them it's just a conversation to begin.
Right.
They're not going to immediately draw your blood and do all these testing. Right. You know, a lot of it is actually just initiating that conversation that a lot of people have never had, to do a thorough family tree and documenting, you know, who has what illness. And at the end of it, they may look at it and say, no, you're fine. We don't need to do any genetic testing. Mm-hmm. Or they may say, you know, you guys really should be checked for this. And so really it's just opening that door for conversation.
I absolutely agree. I have the same conversation with my patients. There are so many amazing questions rolling in. Next question. What is the risk of complications with screening colonoscopies?
So there's about a 1% risk of perforation, meaning injuring the colon. Typically that is related to polyp removal. Overwhelming majority of the time that does not require any surgery afterwards. Sometimes it just requires a day or two in the hospital on some antibiotics through the IV and let the bowels rest. But it's about a 1% risk of colon injury.
Are there any colonoscopies being done robotically?
No.
If you've had a positive screening test and a colonoscopy is recommended, how long is it recommended to wait due to COVID?
Sooner rather than later. As long as you get it within a month or two. One of the things is that cancer, colon cancer is slow growing, and that's why we are able to say, if you have that negative colonoscopy, you're able to wait 5 years, 10 years, just depending on what your risk is. So definitely nothing that has to be done immediately, but something sooner rather than later, so you actually get confirmation of what the problem is and that it can be quickly treated if need be.
Mm-hmm. Another really good question, actually. Is there a connection between colorectal cancer and Herschbachs disease?
Not that I'm aware of. Herschbachs is another one of those rare, actually like pediatric disorders. And so a lot of times if the Herschbachs is aggressive enough that requires surgery, especially in the pediatric age, a lot of times a significant portion of the colon has been removed. But the what Herschbachs is basically the nerve cells within the lining of the colon, and especially rectum, are absent, and so that prevents that motion of the colon moving forward, and people are constipated, they get bloated, and they can't really have bowel movements. Whereas colon cancer is a disease of the inner lining of the colon, and so they're not directly correlated in that sense.
Awesome. And this was I'm going to end with this question. This was a really good question I got last week with Dr. Glasgow's presentation. And I decided I'm going to ask everybody on every single presentation we have, since we are focusing on the African American community. What would be your advice to a patient on how to best advocate for themselves and their families to ensure that they are receiving proper care, timely care, and the most appropriate care possible?
Number one, depending on the relationship you have with your physician, just let them know that, you are concerned, you are willing to proceed with whatever testing, treatment, screening that they recommend, and so that they really take a deep dive and say, and look at your history and have that conversation with you and say, what do you recommend that I do next? What should I be tested for? What should I be screened for? And also sometimes, if you don't feel like your relationship with your physician is as such, sometimes you can actually just even reach out to your insurance provider. Sometimes even in the big old insurance packet that they send you, they have a list of what screening tests that are covered. And so if you don't have that booklet, you could also reach out to your insurance company and find out, at what age do they begin certain screening tests. So then you can even find out for yourself. And, a lot of times you don't necessarily even need the referral from your physician. If you don't have an HMO or something, you can always just seek me out. If your insurance company doesn't require you get a referral from your primary physician, you need a colonoscopy, you could always just reach out to a colorectal surgeon, a GI doctor to do that. So those are avenues you can go to as well, just speaking directly with your insurance company and understanding what they cover at what age and how you can go about getting it done.
Awesome. Well, thank you so much. This has been amazing. Do you have any final thoughts, Dr. King?
Well, just number one, thank you so much to all of you who enjoyed us on your lunch break. But yeah, my number one thing, I think, is just have the conversation. That's my take-home point, whether it's your physician, whether it's your friend. You can find me on Twitter if you need to, at eking719. You can find all the resources on the Northside website, with the Cancer Support Community website. So don't always accept no for an answer. If you really feel like you need further help, seek out help and resources.
Awesome. Well, thank you so much. We appreciate you so much. And thank you everyone for joining us for yet another amazing presentation with Cancer Support Community and also with Northside Hospital Cancer Institute. At this time, I am going to turn this back over to Katie Armsby with Cancer Support Community for final thoughts and to tie up today's presentation.
Thank you both. That was such a great presentation and such a good Q&A. Thank you everyone for entering such good questions into the program chat box. Like Dr. Gore said, we welcome everyone to join us here next week, same time, same Zoom place with Dr. Ronald Anglade discussing prostate cancer. And then the following week, we have Dr. Gore. She'll be presenting on breast cancer in the African American community. And that program will be moderated by Dr. Janine Pettiford. So if you're interested in joining us for those programs, we invite you to visit our website, cscatlanta.org, where you can register. And as we wrap up, Dr. Gore, do you have any final thoughts you'd like to share?
No, I don't think so. I'm going to end the way I did last week. If something doesn't feel right, if you're concerned, you don't have to take no for an answer. There are plenty of physicians around who will support you and make sure that you're getting the care that you need. And don't be afraid to get a second opinion if you feel like that's something you need to do. And like Dr. King said, information is out there. Information is out there. And so there are so many avenues to find it. We have so many resources. And so if you need help with that, any one of us, as well as the resources with Northside and the resources with Cancer Support Community, we're all willing to help you get the answers and the screenings you need so that you can live your best and healthiest life.
Absolutely. Thank you. And I do want to encourage everyone to visit our website, cscatlanta.org, where you can see Dr. Glasgow's presentation last week on gynecological cancer. And thank you, Dr. Glasgow, for joining us again this week. Thank you, ladies, both, for a great presentation. And everyone, we hope to see you next week. Take care.
Bye, everybody.
Bye.
Thank you for joining Cancer Support Community Atlanta for this program. If you're interested in other live or recorded programs, please visit the online program tab of our website, cscatlanta.org, or follow us on Facebook. We'll be sharing additional information on upcoming programs.